My name's Mary, nice to meet you all. Welcome to my presentation today on implementing 24-hour oncology triage service within the Bailiwick. So it's a unique service unlike the UK. These are my details. I am a senior staff nurse in Bulstrode. I've worked there now for 4 years. So I'm going to chat to you a little bit about why, just the aim of the presentation is basically why have I thought of the UCONS and triage tool in Guernsey, a brief background on the tool itself, patient safety, the UK pathway in comparison to the Guernsey pathway, a bit about my master's project because that's how the tool has come about, and the triage toolkit itself. So I came from the medical wards to Bulstrode 4 years ago, and they weren't using any sort of triage tool to assess their patients, and I struggled with that. I didn't know how to assess patients correctly. So I got this opportunity to go to UCONS, which stands for United Kingdom Oncology Nursing Society. I got an opportunity to go to Glasgow to a 3-day conference, and during the conference there was a session about the tool where a few nurses did a role play, and it was very, very useful. So I took it back to Guernsey and I thought, I'd really like to do something with this. So I applied for the Safer Everyday Award in 2018, and I was lucky enough to win the bursary of £500. So we got a lady to come over who created the tool to do a masterclass in Guernsey. We did one Friday here, and loads of different community, A&E, loads of different nurses attended it. We came up with the idea that I could implement it for my master's project, and I did that last year. So why do we need an oncology triage tool? Well, basically it's for patient safety. We have got increasing numbers of patients. We've got, as per the NHS, we've got 30,000 patients per year surviving cancer for 10 or more years, which I'm pretty sure has expanded with all the new treatments, new problems. So we've now got targeted therapies and immunotherapies which may replace or complement to the traditional chemotherapy. These targeted therapies and immunotherapies come with a lot of different side effects in comparison to the traditional chemotherapy, so we need to make sure that we're assessing them correctly, because after a patient finishes treatment they could have subsequent side effects for a year to 2 years after they've had it. And this report, although it's NCEPOD 2018, but a lot of policies are actually still created around it, because they found that the number of deaths within 30 days were found to be related to complications and toxicities of treatment they had received, and a lot of patients did die because of this, so that's why this has come around. These are just a list of some side effects that you can get from our treatments. So this is how the tool is created, is around everything that's listed up here. So the UK patient pathway, bearing in mind this is all free for NHS patients, alright, so they have access to primary and community care, so your GPs for free. They've got their emergency services, so their GP and their ambulance. They also have 24-hour advice lines, which is run by their local oncology unit. They have urgent care, so A&E or AMU, and they also have an acute oncology service, which is their local oncology unit, which basically runs as an A&E department. In Guernsey, we don't have the 24-hour service or an acute oncology service, so we came up with the idea to create a unique pathway for our patients. So the unique patient pathway, we came up with using all our multidisciplinary team in providing this 24-hour service. So weekdays, patients have access to Bulstrode palliative care nurses and the GPs. At the weekends, they can contact their district nurses who are trained and use this tool, and emergency department who also have received training on this tool. And out of hours, they can contact community services or A&E, and they can contact them via phone or go up to A&E. Patients as well have actually received education on self-empowerment, so basically self-management skills, what to do if they have a symptom. Should I be going to A&E? Should I be phoning someone? They are also responsible in reporting their symptoms and seeking advice. This is another thing I got in the conference in Glasgow, was this book. I'm sure, Letitia, you've seen this book. A lot of our patients have this. They take it to A&E, to their GP, and there is a triage tool, a simplified one at the back of the book, which they can do themselves, and it's a traffic light system. Basically it tells them, should I be going to A&E, or should I be calling Bulstrode, or is this normal, basically. So yeah, we fill that in every time they come up to Bulstrode, or if they're going to their GP, they can see where they're at in their treatment stage. So yeah, this is the toolkit up here. Got a copy of it here. If anybody wants to come up afterwards, they can have a look. So the toolkit itself is only for people it's not for all cancer patients. It's only for people undergoing chemotherapy and up to 6 to 8 weeks post chemo treatment, and patients receiving immunotherapy, or up to 12 months after receiving immunotherapy, because they can still get their side effects after that, and anybody going for radiotherapy as well, which is all off island. So the toolkit aim, so basically the toolkit is to help nurses and GPs in all 3 stages of the triage process. So it's the first process is the contact and data collection. So if a patient phones the unit or walks into the unit, it's basically getting their details, so their name, date of birth, what is their diagnosis, and the assessment and the definition of the problem. So it gives you a list of questions to ask the patient, because often a patient will phone and say, oh, I've had diarrhea all weekend, but they actually don't go into the small parts. Oh, I was feeling sick, or I've been in bed. They don't tell us they just tell us the major problem. They don't tell us the smaller problems. So it's important that we assessed it all. And then we come up with the most appropriate intervention or action, so whether that could be just giving them simple advice over the phone, coming up to see us, or going to A&E. So yes, the toolkit provides a simple, reliable assessment process, so it helps us provide safe and understandable advice. And it also acts as a communication tool for us nurses to, we put it into their records, so other staff members can come along and see what's actually happened to the patient over time. It's a competency-based training tool, and we can use it as an audit tool as well. And this is the toolkit itself. This is the long list of questions that we do have to ask patients, but we can sometimes simply fly through it. We just ask the patient their temperature. If they don't have a temperature, it's like a tick box thing. It is based on CRI, CT, CAE criteria, so that's how doctors assess their patients, is using this toolkit, which is quite complicated. So it's a simplified version. It's a risk assessment tool, so you grade patient symptoms. It establishes their risk. Is it high risk? Is it low risk? Medium risk? So as you can see, it is a traffic light tool system, so red, amber or green, and it provides a consistent, robust triage. But you do need to remember, you must use this as a guideline, all right? So if a patient is scoring an amber and you think, I really want to assess them, just use your gut instinct. It is a guideline, all right? And it does provide early intervention for those most at risk. This is the log sheet that we complete whenever a patient phones us. So it's a standardised record format to support the triage process. So it's a guide and a checklist, so everybody needs to make sure that they have ticked their box, because if they haven't ticked it, they haven't asked it. And it is a communication tool, so it's a record of the process of quality, safety and governance purposes. And I'm sure you have picked up, it's graded as red, amber or green. So any patient that is in the red zone, so from when we ask the questions, they should be realistically going to A&E to get an assessment ASAP. So we would phone A&E if it's within hours to tell them that they're coming up to them and provide A&E nurses with extra details. If a patient scores 2 or more ambers, so if in one section, say they had an amber for their nausea, and in another section they had an amber for their diarrhea, well, they should be really going up to A&E to get checked over or coming to us. An amber, so if they scored 1 toxicity of an amber, we just follow them up in 24 hours. But we also tell them if their situation deteriorates to phone us back or to get checked out. And green, we just instruct the caller to call back. So yeah, it just gives patients more reassurance, and it gives us reassurance that we're providing the correct assessment on the patient. So these, each area have their own paperwork. So for primary care, GP, so primary care here have actually attended the training when we initially done it, which was great. And we had some GPs from there who attended the training in Queen's Road, and they were going to educate the other people in their team. Not a lot of our patients attend primary care, but sometimes they do need to. So yeah, this is the paperwork they use, the GPs, district nurses, ambulance when we eventually get out to provide an education for them, and the palliative care nurses have also received training on this as well. This is what we use, and A&E, so we have acute initial management guidelines which A&E and us use. It's about what bloods, diagnostic bloods that we should be doing, and if we should be doing any x-rays, etc., but we liaise with the consultants for them. So that's what Broad Stroud and A&E use, and eventually when we get to provide an education to Alderney as well. And this is what the patients use. So it's really important that our patients do know what to do. So we provide education on this whenever they come for their treatments, so they can manage it themselves if they can. So yeah, that was just a very brief introduction on what the tool was. I will give you an example of the tool in work at the end, but move on to my master's project. So there was 4 objectives with my project, and Vicky kindly helped me out with my objectives. So the first objective was to implement a 24-hour oncology triage service in Guernsey using all the multidisciplinary team, and it is quite unique in comparison to the UK. We don't have the capacity to provide a 24-hour service, unfortunately, at the moment. After our meeting with Philippa Jones from the UK, who created the tool, she decided, well, she told me it would be a really good idea to create a working party with a representative from each area. So we had quite a few meetings, and we discussed what would be useful for each team and how we should roll out the tool into each area, because it was quite important that we didn't roll it out very quickly. I just wanted everybody to understand how to use the tool. So we had a working party, which a representative did attend most of the meetings, and I sent out minutes of the meeting. Then we had teaching and implementation, which ran from October 2019 to February 2020 in each area. We did a few teaching sessions in district nurses, the GP surgeries, and A&E. But obviously COVID came in and impacted on the teaching sessions as well. Okay. So that was objective 1, which we did complete over a period of time. Objective 2 was to explore patient engagement on the newly implemented telephone triage service over a 1-month trial period. So before we implemented the tool, we wanted to see how many, basically a baseline of the pre-existing activities. So staff in the department had to, over a 3-week period, had to complete a small tick box questionnaire on any activities that were outside of the normal from administering treatment. That was from patients walking into the department, phone calls, and 38 activities were logged back then, which was actually quite a huge number in 3 weeks. So yeah, so we had 8% walk-ins, which were discussed with consultants. 21% of phone calls were referred onwards, so that would be to A&E or to their district nurse. 29% of walk-ins were a nurse's advice were given, and 42% phone calls where advice was given. So post implementation of the two, we had 2 phases. I will explain later on in the presentation why we had 2 phases. So phase 1 was only supposed to be over a 1-month period, but we didn't actually get that much data collection, so we had to extend it for 2 months. So we did 2 months, and we had 18 triage systems at the end, or 18 triages completed at the end, and that was from phone calls and walk-ins. And then in phase 2, in February to March, we had 10 assessments completed. So yeah, in phase 1 we had 16 phone calls and 2 walk-ins, and in phase 2 we had 5 phone calls and 5 walk-ins. We're trying to veer away from the walk-ins because we don't have the capacity at the moment for a walk-in. So when we do an education with a patient, we always encourage them to phone us with any problems. So the actions taken, as you can see, there was GP advice was given, seen by the doctor and oncology unit. A&E visits were advice given by nurses, or advice from a doctor was given to some patients. So you can see the difference in phase 1 and phase 2. So the comparison, there was a significant reduction in nursing advice given to patients. No advice was received from consultants. Fewer referrals were made to A&Es. However, because of that, there was a significant increase in patients seen by their oncologists in the Bulstrode, so there was a significant increase in the walk-ins. And GP referrals were made the same. Objective 3 was to evaluate record keeping and the quality of advice provided against the UCON's 24-hour triage rapid assessment and access toolkit during a 1-month trial period, or until significant data was collected within the oncology unit. So basically we got all the tools that we did complete over the 2 phases, and we audited them as well. So from the audit tool, which a nurse in the UK did create, we audited both the tool, and we found that it was 89% satisfactory, but it was just really simple errors where people were not signing the form, or temperature not completed, which is actually quite important with an oncology patient, and the toxicity table was partially completed. So did the nurse ask all the questions, did they not? So 11% was unsatisfactory, and so yeah, it was very simple errors. So from that, we did actually ask staff what actually could we do better with this tool, which is quite important because we do need staff to work with us. So the staff did request that a clear flow chart and instructions on the actions required following the assessment, so what to do when I filled in the assessment. So each area was given a flow chart. So this was the first one I created, which is not very good, and the second one Vicky kindly helped me out in doing, which was great. So this hangs above each telephone in Bulstrode where someone will be doing a triage assessment, which is very useful. You're welcome to come up and look at all the extra bits and pieces afterwards. And another thing that staff had mentioned was the shift coordinator should really be assessing the patients, because if you're working out on the shop floor, it is actually quite hard to assess patients when you're thinking about your patient on the floor with a bag of chemo. So that was beneficial. So when someone ill phones or someone walks in, the shift coordinator has to go out and deal with that. And because of the 89% in the audit tool, my manager recommended that we had a second phase. So once all this was introduced, we had a second phase, and the audit showed 100% afterwards in phase 2. So the quality of advice given, I'll not go through everything on the presentation on the pie charts, but as you can see, 50% of people who phoned in phase 1 scored a red, and 60% scored a red in phase 2. 22% scored a green in phase 1. 6% of people in phase 1 scored 2 ambers or more, so that was a red, and 30% in phase 2 scored 2 ambers or more, so that is a red. So we needed to send them to A&E or for some to come up and see us in Bow Stroud. So some patients were discussed, and not everybody did actually go to A&E. Of the patients that required an origin assessment, various actions were taken. So some patients were discussed with an oncologist within the department due to availability of a specialist at the time of triage rather than referred to A&E. This also affected the increase in walk-ins in assessment. This was also affected by the walk-ins basically in phase 2. 4 patients received clinical review by nurses, and this was documented on the log sheet why this happened, why they didn't go to A&E. And this was the red triggers, the breakdown of it. So 40% of patients in phase 1 were referred to A&E, with 11% in phase 2. 20% were seen by the doctor in department in phase 1, and 56% in phase 2, which is quite a high rise. 20% of people in phase 1 had a clinical judgment and were referred onwards to the GP, and 22% in phase 2, and 20% were discussed with a doctor in clinic. But what was most important was that the nurses who used their clinical judgment did document this and weren't automatically sent to A&E. I'll just go through the scenarios where the people, where the nurses did actually use their clinical judgment. So in phase 1, we had 1 patient who scored 2 reds and 2 ambers. The nurse who did answer the phone to this patient, they already had an appointment with the GP, which they did attend, and they were told to go to A&E because they did have urinary sepsis, so that is quite important. In phase 1, a patient scored 3 ambers. The patient already had these symptoms for 4 weeks. It wasn't a new onset of symptoms, so they were referred onwards to their GP. And in phase 2, 1 patient scored 2 reds and 2 ambers. So the nurse received advice from a senior colleague. Symptoms seemed to be like a virus, so advised if the symptoms persist to attend A&E. Patient was followed up in 24 hours to see were they okay. And then in phase 2, 1 amber, which was not a new symptom. They were referred to the GP and commenced on oral antibiotics. We are conscious we don't want to send everybody to A&E and build up their department. It also is worth mentioning that we do have an agreement with A&E. If any patient attends A&E and they're found to have a symptom related to their chemo or their immunotherapy, and if it is a side effect because of that, they don't actually get charged. But sometimes they do get a charge, and we do dispute it, but not very often, but it does happen occasionally. So clinical judgment, in using their clinical judgment, the correct advice and referral instructions were followed in the majority of triage assessments completed, exception of the 4 ones that I did tell you about. It didn't actually, no patient, it wasn't a poor patient outcome. The patients all did get assessed, whether by a GP or an A&E. Fewer triages were completed in phase 2. This is potentially because of the implementation of this book for patients. This wasn't actually around when I started all this off, so I think when that started, a lot of patients did take it upon themselves to read their own triage systems. So it contains a simplified classification of symptoms for the patient. There was a decrease also of referrals made to A&E in phase 2, and consequently our walk-ins increased. And the objective 4, so it's important to see what patients actually think of the trials tool itself. There's no point in implementing a whole new system if the patients actually don't like it. So to explore patient satisfaction on the service provision using a questionnaire over a 1-month period. So I just used phase 1 only, so all the triage tools that were completed in phase 1. So 14 patients were identified as appropriate to be offered in the patient questionnaire, so 4 patients were excluded due to ethnical reasons, and I didn't really want to cause any distress to the patient themselves or their family. And 3 patients had 2 assessment tools completed on them during this phase. So there was 11 patients received a little letter. So 11 patients were suitable to complete the questionnaire, and we got 100% feedback. 100% of questionnaires were returned to us using the free postage envelope. The questionnaire did contain 9 questions, so it wasn't an overly long questionnaire, which is also important. So there was a lot of tick boxes. So I'll just fly through these. Did a member of staff tell you what to do if you were unwell? Yes, I'd like to think so. So they all responded yes. Did a member of staff tell you what side effects you should report? And they all said yes. If during your treatment you were felt unwell, what advice was available to you, or was advice available to you? And everybody said yes, apart from one, it wasn't necessary. So I'd like to think maybe that they might have used the book themselves, I don't know. It was anonymous, so I didn't know who responded or who didn't. Question 4, where did you seek advice if you were unwell? So 7 people phoned Bulstrode, 2 phoned A&E, which is quite useful to know because I never know where those people phone. 3 attended Bulstrode, 3 attended A&E. Nobody seen their GP. It wasn't necessary, and 1 person was other. So I assume that probably was that it was not necessary. How satisfied were you with the advice given? 7 were satisfied, 1 was indifferent. How satisfied were you with the nurse's level of knowledge? And everybody was satisfied. Did you feel the side effect table in the record book to help you to know where to get your advice? So 6 said yes completely, 1 to some extent, which I think is explained later on in the slide, and 1 said other. 1 person didn't actually have a book because they're on long-term treatment, so this was a new book that was rolled out to new patients, so I think people who are on treatment didn't get one at that time. What improvements do you feel, if any, could be made to the telephone advice service? So there were all good reports on the service, but there was one that 1 person wanted most people wanted it to be 24 hours, which we simply cannot do. It would be great if we could do. And other comments, one of the comments was that the book needed updating for immunotherapy patients. They felt that the book was more chemotherapy sided. I did email the Cancer Research UK, and they actually said that the book is for immunotherapies and chemotherapies, which I did find as well. There is to do simplify things for immunotherapy patients, so I think it is for both patients, it's not just for 1 patient. And they found the treatment in the unit and A&E to be beneficial. So obviously each study that you do does have limitations to it. So it was a unique Plan Do Study Act service improvement study to serve a small oncology population on a small island, so it was a small sample size. I'm sure if you did it in the UK it would be a lot larger. So I was limited to data collection from 1 hospital, and I was just more focused on the oncology department. We also must remember that a lot of our cancer patients don't have a specific CNS nurse, so head and neck cancers have no support from them, or lung cancer patients. So we are their main support, or the palliative care nurses are their main support. And due to operating on a small island, we are very familiar with all our patients, so that could have influenced their responses. And the cost to access primary care in A&E made the service improvement more difficult, but during that time we came up with the A&E cost thing, which was very useful during the project. Another limitation is we don't have any acute oncology service, which I don't think we have for a while, and we've got no junior or senior house officers, so we just have the oncologists which do run clinics while we're running our clinics as well. And the oncology team did actually benefit from all my master's project. You know, when I sent out the questionnaires and we networked with all the community nurses and the GPs, so maybe we'll be able to sustain this service in the future. COVID-19 did as well impact on the service. And yeah, I never did research before, so this was all new to me as well. And that was the flowchart which I did discuss earlier. And so the conclusion, well, we did successfully implement the tool using all the multidisciplinary teams. We collected qualitative and quantitative data, was obtained, patient engagement and evaluation of the record keeping was achieved. Sorry, I'm getting lost where I am now. Yeah, so the audit accomplished the quantitative data and all the triage sheets were completed in phase 1 and 2. We also explored patient engagement and evaluated record keeping and the quality of advice provided. The results did improve in phase 2 following the necessary changes that were established in a bid to sustain the service. It was a small sample size, but we did get a 100% rate in the questionnaire, which is very useful in terms to maximise the qualitative data and enhance the qualitative data that we received. I'm sure if we did this project elsewhere in larger populated areas, the research indicates the necessary need for a 24-hour telephone triage service. We still use our cancer research books and patients do find them very useful, so we have continued to do that, provide them with their books, and Cancer Research UK do kindly provide them free to us for our patients. Further research is needed on patient empowerment strategies as a cost-effective method to sustain the oncology service here in Guernsey and improve patient outcomes on managing their own toxicities. But I definitely have found since I arrived in Bulstrode 4 years ago to now, our phone calls and walk-ins are not like what they were 4 years ago till now. So some days we mightn't hear the phone at all. Mondays tend to be our busiest day, but that's how it is. Next steps in the project, whenever we do get more staff, so hopefully in maybe 2022, we are a little bit busy at the moment. I would like to work, and St John Ambulance did attend the masterclass, and they do seem quite keen to work with us and provide the service as well, which would be very good for our patients because they'll be getting the same assessment everywhere in A&E or in the ambulance or in the GP, would be very useful. So UK Hospital Trust have actually implemented this tool, so I'm trying to contact the lady who did that. Word of mouth from the hospice and other our sister island Jersey, they have heard of this tool being used over here. I think they use a similar tool, but I don't really know what they use, but they would like some training in it and just to hear what we have been doing. So training and education will continue, and especially in the areas that we have provided training already. So yeah, continuing education for the relevant multidisciplinary teams to continue the audit. So yeah, we would like to re-audit the tools in our department to see how we actually doing and are we slacking or are we getting any better. And we would also like to roll out the audit in other areas as well, because it's important that they're actually using the tool correctly, or if they need any extra education, or if there's anything they're finding incorrect with the tool. In the pre-treatment sessions for patients requiring treatment, SAT is the main name for all the treatments. We do emphasise empowerment and self-management of symptoms. Yes, we encourage our patients to phone us, but it's important for them as well that they know what is normal and what is abnormal. So that's what the simplified tool is in the back of the book. I think we do need to develop a policy outlining the roles and responsibilities of each practitioner. This will reduce the risk of liability, and it's also important for ongoing monitoring and audits. Thanks for listening. Any questions?